We'll invite our next speaker up, representing the Hepato-Pancreatic-Biliary, representative from the AHPBA, Dr. Rohan Jeyarajah. So he's an associate professor at the Methodist Dallas Medical Center in Texas, and is the director of the surgical oncology and the HPB and upper GI fellowships there. So please tell us what it's like to be an HPB surgeon.
Great, thank you. I realized probably says a lot about me that I should have used the background that they provided, so I did that because most of my background's usually purple or something crazy. So, so pancreas cancer is purple, right? So we have to use that color. So I'm here representing the AHPBA, which is the America's Hepato-Pancreatic-Biliary Association. Say that 3 times over, would you? and I'm also vice president of the Fellowship Council, so I have a fair amount of sort of experience with the Fellowship Council mode of training. I was chair of accreditation for way too long, but got to know a lot about the accreditation modules. So a little bit about what is HPB surgery, because I think probably this is one of the newer fields with response to, with regard to subspecialization. Because when I was a resident, general surgeons did all of this stuff. And so what's happening now with the change in training paradigm is HPB is really surgery of the liver, pancreas, and bile duct. But it's not just that. It's really a knowledge of benign disease, malignant disease, chemotherapy, radiation, and also critical care. And for this reason, I think it really brings together the gaps or the best of transplant surgical oncology, complex gastroenterology, interventional radiology, pathology. And, the knowledge of both benign and malignant disease makes this especially difficult. And then you've got to throw technology into that too. And you've got to be able to do things with an MIS approach as well as with an open approach. And that's daunting to train people in these areas. You'd asked us to talk about how HPB cases can be challenging, and I think, like you heard beautifully from Jim, the knowledge of oncology is so critical, and it's one of my pet peeves that people who operate on the liver, who don't know what FOLFOX is, really just should not be operating on the liver. So you've got to know the medical side of things first. You also have to know benign disease, and I think sometimes this is the hardest things. For example, a complex pancreatitis patient actually can be so challenging, give me a good old cancer any day. And you have to be technically aggressive, but you also have to be thoughtful. So one of my pet peeves is, one of the papers looking at liver resection, 25% of the patients that were done MIS were actually FNHs or hemangiomas. So you've got to know what to operate on first before you use the technology. And then I think one key thing from the trainee standpoint is if you don't like sick patients, HPB is probably not the field for you. Because my census is usually in the 10 to 20 range, and it's at least 1 or 2 patients in the ICU. So why has HPB surgery become its own field? Well, you've heard things are just much more complex than when I was a resident. When I was a resident, it was like, mass, cut it out. Now you've got to think about, what are the implications for chemotherapy beforehand? What are the implications for radiation therapy? Do we have percutaneous options? Can we downstage with this, etc., etc.? The other thing that you heard about was regionalization of care, and I have such mixed feelings about this living in the center of the country because I'm in Dallas, because I was just telling Jim, I have patients that get on a bus from El Paso in a yellow and travel 12 hours to come and see me, and I wish there was somebody closer to them for their own sake, for the family support sake. Outcomes have improved though if you have the system in place, and so my sort of I do a lot of helping people out in the community, in rural communities by, looking at imaging or, getting on the phone from the OR or whatever to try and remotely help as much as I can. Because I don't think everything needs to come to me. And everyone has become organ focused. So the Fellowship Council, just a word about this, because I do want you to understand that this is, when I was a trainee, I thought if you were going into a non-ACGME track, that was sort of not as good. And truthfully, that has been a a bit of a hangover for a long time, but sitting as chair of accreditation, I can tell you, and those of you that have Fellowship Council programs, this is a really rigorous process. We require a site visit, and it's a 3-year cycle that has been the case. And I can tell you that 15 years ago, things were a little bit different. Things really got tight about 12 years ago, where we really tightened up the accreditation process quite a bit. So I think this is very robust. So back to HPB. You have to have at least a 1-year clinical training program. About half of our programs are 2 years, and you have a handout that's outside that has a list of all the programs. You have to include both benign and malignant disease. You have to have some exposure to MIS techniques, and that may or may not include robotics, ultrasound exposure, and ablation exposure. These are the guidelines for case volumes, and we require 25 pancreas cases, of which 20 now on our recent guidelines have to be pancreatic duodenectomies. 25 liver cases, of which 15 need to be hemilivers. We just altered that guideline to include posterior sectoral resections or central hepatectomy, because as those of you that do this know, that's actually more challenging than a straight right liver. And then biliary cases, 15 or so, and our program is, I don't know what it is, but I have a ton of ampullary work, it seems, that count as biliary cases. So before I just do the Whipple, but I'm getting better at transduodenal work now. So a total of 100 cases. And really, when you think about that, that is such a low number because it's only 2 HPB cases a week. So this is a minimal bar. Most of the program have over 200 cases. The AHPBA does provide a certificate of completion, and the program director applies for this. You have to be in a Fellowship Council program and meet all the case requirements, and we sign off on the clinical and didactic requirements. Now, what I do want to tell you about was I got the SSO, the ASTS, and the AHPBA in a room together last October, which was like amazing because these 3 societies are very competitive, and we actually came up with what I think will be a framework for a common certificate process down the line, potentially. We have a lot of work to do, but I think it would be good for the trainees if there was very clear transparency around things. And as Dr. Pingpank mentioned, you know, there are a lot of HPB SSO programs that do a great volume of HPB and should be known as that in addition. So. The certificate is presented at the AHPBA meeting, and again, I won't go through this, but these are some of the, this is the list of programs. I mean, these are really like pretty amazing programs, really great calibers programs. I'm actually chairman of the Program Directors Committee for the AHPBA, and I keep looking around the room and thinking, I'm like a little guy in private practice. I don't know what I'm doing with all these big names, but it's really amazing, and they're so collegial, and they're really great to work with. The great thing about the certificate you can see is that we actually have some combined programs with the SSO, which is wonderful, and also with the transplanters, where they provide amazing HPB exposure within these programs. For example, so MD Anderson has chosen to do a 3rd year, which is separate from the SSO program. Pittsburgh has a separate HPB program, so it just depends on where you are. WashU and Toronto are the 2 ASTS programs. So what are we looking for in applicants? I was really interested to hear about your survey because we did exactly the same thing. We have a fellows subcommittee, and it was very similar. It was sort of this personal aspect was what we were looking for. You really, you know, I always say when you're a resident, when you're dealing with residents, they usually rotate right after 1 or 2 months, and even if you want to throttle them, there's somebody else that comes on. Or if you love them, you know, it's like, I just lost this great resident. With a fellow, you're stuck with them for at least a year. And I see more of our fellow than I do my own family. So it's really like really personal, okay? So you want somebody that you can really work with, that really wants to be in your program. The one thing that we keep getting asked about, and you know, I didn't put match statistics on here, but most programs, for the HPB programs, there's actually about a 1 to 3 match rate. Unfortunately, there are about 19 spots each year because some positions are every other year, and there are about 65 applicants for those spots. So it's becoming more and more competitive. So we're seeing a lot of people who have already done a fellowship, most commonly MIS or or surgical oncology. And I think that that's really nice, but it's not essential at all. We're just looking for somebody who really wants to be there and somebody who has a little of something else, whether that be personality, whether that be research, whether that be a great story, whether that be a talent, in some other way that you've really shown us that you've followed through with that. You've knitted the best scarves for your whole life and you've won this award. I mean, whatever it is that you've shown passion about, like Jim said. So for me, what happens afterwards, I think it is really unrealistic to think that you're going to go out and be the central pancreatectomy expert in Dallas. That's just not going to happen. So realistically, you have to understand that there's going to be an other to your practice while you, and it falls on you, take the responsibility of growing that HPB practice. You have to be able to grow it. And so the issue is, for me, that other is foregut and general surgery. I think if you come out of the SSO tract, maybe it's breast melanoma or the other tumor sites that Jim mentioned. For the transplanters, that may be transplant or vascular access. And this was, sort of a terrible graph that I put together. But basically, for me, this was my career, which was that it started out, taking trauma call at Parkland and doing, gastric bypasses and things like that back in the 90s. And then as time got on and I showed ability and interest, and really it was more about interest because my abilities are terrible, gradually this dropped off and then this goes up. So I think that you have to figure out what that other is going to be. And I think if that other is, complex general surgical oncology, that would be a great way to train. If that other is going to be foregut, then maybe MIS would be the best way to do this. So this was kind of the best way that I could put it together. I think that's it. Thank you very much.